The reason is, two reasons. One thing is the ICD shocks are very painful. Second thing is the device gets exhausted in the next day. So a 5 lakh rupees device gone because of one VT storm. Then you connect them to the external defibrillator, work up for reversible causes. See, this one particularly, I will tell you, post-CABG patients are one patients, and especially if they have undergone bypass recently, please have a very low threshold for doing a coronary angiogram on them. Because we have seen particularly ungrafted vessels causing VT storm. All you have to do is stent one of the vessels. Makes a lot of difference. And then we did see patients who had thyroid storm and other things which are, particularly this, I would like to emphasize on coronary angiogram for patients who underwent recent vascularization. Then once you do the reversible causes, this is the most vital, important. I'll take a minute more. The most important person in the management of VT storm is anesthetist. Now all these patients must be sedated, knocked out, and if necessary, mechanically ventilated electively. Because once you do that, the sympathetic outflow decreases, the patient becomes knocked out, so the shocks are not painful, and the adrenaline effect on the heart also decreases. Then optimize the beta blockers. There's nothing like dose of beta blockers. Just get to the heart rate of 50 to 55, no matter what you do, IV or whatever. And once you do, and mechanical ventilation, then comes either then these are, bilateral sympathectomy and ablation. Ablation is a mainstay in many of these patients. So when you look at these patients' electronegative mapping, what you see is, I'm not going to emphasize, just to give a pass through. These patients have these kind of, as I showed before, this is an area of scar, which is a previous myocardial infarction. These are the areas of live tissue and the borderline zone. You see very abnormal potentials. You see there's a QRS complex, ECG QRS, and you see the local electrogram is so far away. It's a late potential. Sometimes these potentials are fragmented. Continuous electrical, like you can see they're fragmented, they're not sharp QRS complex like we see. And they are double potentials, multiple, instead of one potential you see. These are abnormal potentials. So we painstakingly, each of these potentials we target and ablate in all these scar areas. And once these are done, at least you get rid of the storm and you come out of this crisis. So in our experience, we had recent few years, we had 16 patients with the same algorithm we followed, either recurrent VT or recurrent ICD shocks. And we found the reversible causes in these patients, one thyrotoxic causes, two ischemia. One was the ungrafted diagonal of a patient, another patient had, both of them obviously was stented. One patient was heart failure causing this one. So these patients, all of them, you can notice that out of 16 patients, 15 of them mechanical ventilation. We have very low threshold for them, immediately we ventilate them. 2 of them received IVP and 12 of them had electronegative mapping. The good thing is 2 of them passed away in the hospital, we couldn't save them. The remaining patients who survived, 14 patients, at follow-up of almost 2.5 years, they're doing without VTs on the ICD interrogation. So 86.5% survival of a VT storm, which otherwise, as you all know, the survival rates are less than 10% untreated in the historical. So in conclusion, VT is the most important contributor of sudden cardiac death and has to be aggressively managed. Beta blockers and amiodarone are the main drugs for post-MI VT. VT storm needs protocol-driven management. Every institution has to make a protocol and this protocol has to be followed. And benign VTs are important. These are one small VTs. Our VTs are very scary, but benign VTs are one thing which needs to be recognized. And they have specific ECG patterns. The important thing is, as I repeat, they are recognizable and they're curable by radiofrequency ablation, and they don't need ICDs and they're not associated with sudden cardiac death. The patient has a VT in acute myocardial infarction in hospital. What is to be done? Now, surprisingly, the guidelines have sorted out the matter very clearly. Now they say that if you have a VT 48 hours later, these are the patients who are at risk of sudden death and need ICD, 48 hours after myocardial. Now, having said it, you have to qualify this statement by a few things, riders. One thing is, again, as I said, you have to see, is this a monomorphic VT or a polymorphic VT? If it is a polymorphic VT, these are the patients who generally have reversible factors. They don't need ICDs. You either see if there is ischemia, which is the most common thing, which is seen as a long QT, if not necessarily as a chest pain or ST elevation, can be even seen as a long, prolonged QT. And second thing is, even if these patients have multiple polymorphic VTs, the way to treat them is by ablation in the acute setting, and not by ICDs. On the contrast, if the patient has a monomorphic VT, 48 hours later, even one episode requiring intervention or whatever, I think these are the patients, and invariably they have scars and LV dysfunction. I think they should undergo a cardiac MRI pre-discharge, confirm they have scars, and I think these are the candidates for ICD. Thank you.